Welcome to MPNUniversity.TV Clinical Insights. This discussion is about deciding the choice of therapy for polycythemia vera and is moderated by Dr. Richard Silver. Our panel discussants are Dr. Serge Verstovsek, Dr. Rubin Mesa, and Dr. Susan Leclair.
Hello, welcome to our session on the myeloproliferative diseases. I'm here with several of my colleagues and friends, and we're going to discuss some aspects of polycythemia vera. Rubin, there are a number of formal classification systems in the myeloproliferative diseases, and I believe you, as part of the international working group, participated in some of these. Some people have criticized them by saying they're too unwieldy, this DIPS score and IPS score. And, I mean, you're an experienced clinician and helped develop the symptom scoring system. How do you approach this issue?
Well, it's a good question. First, I try to separate the issue of really rigid criteria that are involved with clinical trials in terms of having a similar population and a similar exact set of response versus clinical practice. In clinical practice, I think the ones that are the most relevant are really one around diagnosis. So the WHO diagnosis of polycythemia vera is a helpful starting place. I know that that's an area where you've had a lot of passion, but it helps to identify kind of key clinical features that we find with the disease. Erythrocytosis, the presence of a molecular marker, to really help to confirm that an individual has that disease. The other aspects in terms of response criteria are helpful, as are the other criteria that are developed, but some of them that really are quite strict are really meant for the rigidity of clinical trials and having accurate data. I think as I convey to our hematology fellows that are learning hematology, that the key things with criteria is people are trying to remember criteria in MPNs, MDS, CML, myeloma, lymphoma, there's so many of them, is to really identify what are the themes that those sort of criteria are telling you about the respective diseases and the risks that risk scores identify.
Thank you. And Serge, you've have been involved with some significant clinical trials in polycythemia vera and myelofibrosis. How do you use these scoring systems, or do you not when you see a patient in consultation?
I think this is a very good point to raise at this moment in time, because we now have medications that to a large extent control the symptoms of the patients. And that was not the focus of our implementation of therapies until recently, until only a few years ago. So in polycythemia vera in particular, we have guidelines when to start the therapy based on age and history of a blood clot. But what if the patient is younger and never had a blood clot and suffers from significant symptoms related to polycythemia vera? Should we intervene because of the presence of the symptoms? Using the tools that Rubin has developed with others. These are myeloproliferative neoplasm symptom assessment scores, the questionnaires that can be easily implemented in everyday practice. In our center, we do ask every patient when the patient comes through the door, not just about the blood cell count and assessing the spleen, we ask them questions using that tool, the questionnaire, how do they feel on different aspects and questions, and it's part of a clinical database. Should we use this information to implement cytoreductive therapy in PV? Is a question that bothers me, because we know that patients may suffer a lot from these signs despite the good control of the counts. And similarly, the question is, should we also have assessment of coagulability in that particular patient, which is at a risk of a hypercoagulability event, despite the control of the blood cell count? Should we also implement that as a standard practice to guide us for the cytoreductive therapy?
So, Dr. Leclair, there have been many studies assessing hypercoagulability in the myeloproliferative diseases, and I think we all would agree they're faulty. Would you think that this should be part of the routine workup of a patient, considering the time and expense that's involved?
I would think that the patient's symptoms would guide you on that. If in your discussion with your patient the word headache doesn't come up, or the tingling of fingers, or those things that you would would judge to be potentially clogging small capillaries or potential small microclots that are forming and dissolving. If that doesn't happen, then I probably would suggest that you not go down the road of expensive testing. But if you do hear those things, and after a while in your relationship with your patients, I'm sure that you get and I got bruised right there. And if that's happening, if all of a sudden your patient is bringing them to your attention earlier in your discussion rather than as an afterthought, then I think coagulation testing sounds like a good thing to at least begin. Try and get a baseline study on things so that you can see how things are progressing. But those are things that I think truly belong to that patient-physician discussion. And that, of course, is unfortunate in the sense that many of your patients may not feel that they should tell you things. I mean, we have all discussed at earlier times how do you feel? I feel fine, which translates out to I don't want to talk about it. And how you get through that fog.
Yes, sir.
May I ask a question to complement this? We put everybody on baby aspirin. Do we agree on that? I think we do.
Usually.
Is that right, or shall we do something different?
The nice part about being a PhD is that I can say that's not part of my job. I can tell you that, at least with baby aspirin, we can tell you an outcome of platelet aggregometry to let you know how much effect that one aspirin or 2 aspirins a day is having. I can't do that with the novel anticoagulant, like Plavix and the others.
So perhaps just to follow up on Serge's question, because there's much discussion, in terms of the in vitro studies, what is the difference between the 81 milligram of aspirin and the 325?
There have been some studies that suggest that some people, particularly those who already have a background of chronic inflammatory disease, need to have a higher level. But 325, is a little too high for most people. Some of the cardiac studies in particular seem to indicate that the 81 gives you a pretty good bang for your buck. You're not going to be doing something expensive, Plavix again being my example on that one. You're not going to be over-medicating them so that you're not looking at a risk of stomach bleeding or ulcers or any of the other side effects that aspirin can have. But you still get some depression, and a permanent depression, not a temporary one like ibuprofen, a permanent depression of platelet activity.
Right. I think it's important to recognize that we tend to forget that the thrombotic risk in polycythemia is both small vessel and large vessel, and the low-dose aspirin will not affect the big vessel thromboses that certainly cause a lot of disability in patients with polycythemia. So it really is restricted to essential thrombocythemia and microvascular disease, and polycythemia when you're getting the same kind of symptomatology.
I feel like I'm saying that the laboratory is just not supportive at all, but obviously if you've got a 55-year-old who's a polycythemic and whose family history screams cardiovascular disease, you're going to be looking at that person differently than you would a 40-year-old who runs marathons.
So Rubin, now we have all this laboratory data, and whether we use the DIPS score, the DIPS plus, or your very detailed symptomatic assessment form, how do you decide on which drug to use? Now there is Hydrea, there's interferon, there's ruxolitinib. What's your evaluation of the situation as of 2015?
Well, certainly my assessment of initial cytoreductive therapy and my management of patients with P. vera really revolves around near universal use of an aspirin based on the ECLAP data, except if someone is aspirin allergic, as well as a good tight control of the hematocrit. Although there are limitations in the hematocrit, I certainly look at 45% as a ceiling as opposed to a median, and that I see a lot of individuals who spend time above 45 if they're only phlebotomized after they cross 45. Regarding cytoreductive therapy, I think in 2015, still the frontline therapy question is one between hydroxyurea and interferon. I think there are cases to be made for each, and I think that the upfront frontline studies are important. I have seen patients who have done beautifully on each. So I think that there is some degree of individualization which may come out of that, but I do think that those frontline studies are essential to really define which is the most appropriate frontline setting. I think there are patients that clearly have had strong unmet needs, and I think that's where ruxolitinib came in. I think approved for patients that had failed hydroxyurea. In my eyes, I don't think patients have to fail hydroxyurea to benefit from ruxolitinib. If they failed interferon, I may well consider it as well. In particular, if they're having difficulties with stubborn symptomatic burden, splenomegaly, more refractory disease features, movement toward myelofibrosis. You know, this is a disease that exists in a spectrum, so I think individuals that have had the disease for a longer period of time likely are enriched for being able to benefit from that. So I view that as a very important addition in the armamentarium. Between those three drugs, I'd have to say it's actually quite rare that I think about a drug other than those three in that setting. It'd be very rare for me nowadays to go to a busulfan or another myelosuppressive drug. That's probably my fourth drug in the mix, but it'd be pretty rare for the individual that really had an issue with the other three.
So, Serge, you've had a lot of experience in this issue. What is your approach? Because it's such an important one now that we have three active agents, and as Rubin said, we have busulfan in the outfield, so to speak, and we know that it does affect JAK2 levels.
So I think there are several aspects here that are worth mentioning. First is the first line. 100% agree, and the guidelines are in place. They have been changed to incorporate interferon as equal in a first-line setting to hydroxyurea, and in particularly is useful in younger patients that can tolerate it, because older cannot tolerate it, and because it has biological input on the disease itself. About 20% of the patients will eliminate cells with the JAK2 mutation. The other cells with other mutations may still persist, but we can definitely have a major impact on the tumor burden, if you like. And that is valuable long-term. People can then benefit from the therapy long-term. The tolerance of interferon is still a matter of debate, particularly with the long-term, not yet published, but reported in public domain at different meetings, long-term experience with long-acting interferons, when in two studies so far, one in France, one here in the United States, about half of the patients are off by 5 years for different reasons, but they are off. Many of them because of low-grade myelosuppression or autoimmune problems. So I'm a little bit worried about longevity, if you like, or ability to deliver interferon long-term decades, which I would like to in 45-year-old person who needs cytoreductive therapy. So I'm looking forward to the studies that Rubin mentioned in frontline setting, interferon, long-acting interferon versus hydroxyurea, that is done here. And I would encourage everybody with polycythemia vera to consider that. And a new one in Europe that is a long-acting interferon given every other week, even less frequent, which is tested again in polycythemia vera patients versus hydrea or in a second line as well. So these are important developments for us to deliver valuable biological agent without the leukemogenic effect in patients with polycythemia vera that need therapy.
Right. So outside of a clinical trial, then, gentlemen, I would assume that you would think the decision still has to be individualized. Is that, am I saying that?
I think so, but I think I certainly agree with Serge. There's a front line, and then there's the second line.
So the second line is an important issue. Obviously, if you start with hydrea, use interferon. If you start with interferon, you can use hydrea. Ruxolitinib JAK2 inhibitor is now a valuable option. I think Rubin eloquently described its position. We cover with these three medications a large majority of the patients. I really hesitate to use any other chemotherapeutic agent because there are many studies, and you are very aware of these retrospective analysis from many different registries, that use of another chemical after hydroxyurea,
another
alkylating agent. So chemo after chemo leads to very high risk of transformation to acute myeloid leukemia. So if the patient is on hydrea, I would really hesitate to give this patient as a second line busulfan or anything like that, because of a very well described risk of a high risk of transformation.
Right. All right. So, Rubin, in the context of what has been accomplished, and there's been so much in the myeloproliferative diseases, what do you think are some of the unmet needs?
Well, I think specifically to P. Vera, seeing many patients with a broad range of ages, thinking of saw almost 10 patients this morning with a range of needs. And a key need that people share is really a better understanding of why their disease can progress and how can we be a bit more definitive about trying to avoid progression. You clearly have reported, and there clearly have been patients, I think, who have progressed slower or didn't progress because they were on interferon, but not all. I do believe JAK inhibition may well have an impact on delaying disease progression. Serge's data regarding bone marrow fibrosis in myelofibrosis leads me to be very intrigued that that might have an impact in these patients as well. But a big unmet need is us really understanding why do people progress? And could there be some surrogate marker that I don't think we've yet identified of knowing, are we really avoiding progression or not? As I sit with someone who's 34 years of age or 41 and is really fearful of what the future holds at 51 or 61, that issue of progression and being more definitive around knowing that our therapies are controlling it or complementing our therapies to be more definitive about controlling it, a key unmet need.
But I think that you had a good data in, I think, 55 patients, the long-term follow-up that you published, that interferon, if can be tolerated and given for a very long time, can potentially has this biological effect of preventing patients from having not just thrombosis, but also progressive myelofibrosis in bone marrow.
That is correct. And also avoid the vascular complications. But that's very similar to the French data and also to the Danish data that we all seem to share, that interferon has this effect biologically on not only the hematopoietic system, but also on the vascular system. Dr. Mesa, we're all not molecular biologists, but do you think gene sequencing would give a better marker than JAK2 levels, both for diagnosis and evaluating who? I mean, one of our main problems that we all share is who's going to progress and who is not. And that helps determine what we advise patients. Do you think there's going to be an immediacy in that?
Well, I think the gene profile of patients is going to play an important role, but I don't think it does quite yet. I think part of the difficulty is us understanding that data. Being involved with genetic sequencing in our role in our cancer center, not only in MPN patients, right. It's really understanding that data that is a bit of the challenge. That I think there probably are markers there, but for the moment we still don't quite know. So kind of key questions. I've been on interferon for 4 years and my counts are normal. Should I stop? Am I okay to stop? Or I've been on for 6 years and I have some toxicities. Should I stop? Have I maximized that benefit? Is now the time that I should consider a second-line therapy because I've been on a while and I have some toxicities? I hope that we learn more about really being able to assimilate that information into useful clinical guidance.
Well, that's an excellent summary.
Yes, and to add the molecular aspect of that, we in a research setting, not that I would do this in everyday practice, do measure the JAK2, what we call allele burden, simply the number of cells with the mutation. And it can go away, and then the patient would say, should I then stop interferon because there is no JAK2 mutation anymore? And my approach is no, because I don't really know what that means. Cells with other mutations may be present. So we learn as we go.
Yeah, well, as you know, the French are stopping.
I think it's also true that we need to have more supportive tests for the genetic interpretation. If someone has a marker, okay, you know that it's a marker. But if you also know that that person's granulocytes are not behaving in the respiratory burst the way they're supposed to, or you also know that there are other functional tests of the immune system could be made available, then you would be able to have a piece of data that is understandable. Just telling people or just knowing, oh, you have this particular marker, doesn't help you unless you can correlate it. And there are so few of those markers and correlation studies out there that I think one of the things that patients are going to want quite frankly, is give me that genome and then tell me the truth.
Right. Well, ladies and gentlemen, thank you for a very spirited and informative discussion. Thank you.
Thank you.